Hey guys, sorry for the delay. Just give me a second, please. Hope I'm audible and visible. Hey guys, sorry for the delay. Hope I'm audible and visible. If so, tell me hi, hello. How are you guys doing? We're seeing after a couple of days. Hope things are good at the end. Can you guys see me? Can you guys hear me? I'm having a crack in the behind the head. Okay, so let's go to one more session of MCQ practice. Hope I'm audible and visible. Good evening, Lion. Good evening, Matt. So let's go. And we saw the first half of MCQ practice in the previous session. We saw about good evening, Shreya. The little bit of cell injury, cell adaptation, and few MCQs regarding necrosis, right? So today we're going to look at apoptosis, intestinal accumulation, and maybe a few miscellaneous topics in the first chapter. Same way, I'll try to cover maybe maximum 10-12 questions today. And let's do this again for the next inflammation chapter. Then let's go on with the routine RRR series. Fine. So if you missed, wishes there was a offer will be there till tomorrow. And if you're in third year or second year or first year, whichever you want, please use that and purchase whatever you wish like. Fine. Let's go ahead. So tell me what's the right answer. I'll keep quiet for some few seconds and then let's go and learn something about it. What's the right answer? Whatever comes to your mind, right or wrong, doesn't matter, just comment. Nayak has gone with B. Okay, Lion has gone with B. These are primarily questions which is from DPP. So I'm just taking them, and if you've not done it, please, if you're an essential batch user, please go and do the DPPs. Okay, the question is the role of BCL2 in the intrinsic pathway of apoptosis. Before going to the question, tell me what is BCL2? Is it a pro-apoptotic or an anti-apoptotic? Very good evening, Rahul. Hope your exams are over. BCL2 is a pro or anti-apoptotic? It is an anti-apoptotic, right? So it's an anti-apoptotic, as the name says, it's going to prolong the cell survival. It's not going to let the cell die, right? So here, inhibition of caspase will not be the answer because BCL2 does not do directly anything to caspase, right? Caspase is always in an inactive form. I have to activate them, that's all, fine. Promotes DNA repair. Again, BCL2 is not involved in anything with DNA repair. It definitely will not enhance cell destruction because, like you guys said, it's an anti-apoptotic gene, right? So what basically BCL2 does is it prevents the exit of cytochrome C. It's an ion channel, it just blocks them. What's the function of cytochrome C? Cytochrome C has one important function. The function of cytochrome C is perfect. It's one of the important thing which helps in the electron transport chain, right? It helps in the production of ATP, helps in the electron transport chain. So if the cytochrome C comes outside, the mitochondria will not work, and the mitochondria, if it doesn't work, the cell is going to die, right? So BCL2, which is an anti-apoptotic protein, the function is to prevent the exit of cytochrome C so that the cell can become active. When the APAF will become active, when the BCL2 comes outside to the cytoplasm. Okay, line? Inside the mitochondria, the function of BCL2 is to help in the ATP production. Okay? Okay. Next question. Let's see if we can give the right answer. Whatever comes to your mind, tell the answer. It's fine if you're wrong, but just comment A, B, C, or D. You still have 25% getting the right answer, even if you comment randomly one alphabet. What's the characteristic feature of apoptosis regarding inflammation? Okay, 2 C's. Anything else? Again, one more C. Apoptosis, it's a very simple question, a basic question, right? Apoptosis is never followed by inflammation. Apoptosis leads to release of inflammatory mediators. No. Apoptosis is not followed by inflammation. Yes. Apoptosis will never cause inflammation, right? Now my question is, if apoptosis is not going to cause inflammation and necrosis is going to cause inflammation, what is the reason that necrosis causes inflammation? Can anyone tell me why does necrosis cause inflammation and why does apoptosis doesn't cause inflammation? Whatever you said is right. It will not cause inflammation. My question is why? The simple reason is in necrosis, what we'll have is we'll have a cell membrane damage, right? In necrosis versus apoptosis, one of the major difference which is seen in necrosis will activate phospholipases. Okay? They'll activate phospholipases. So once you activate phospholipase, the cell membrane will be damaged. Perfect, Shreya. The intracellular contents will come outside. When the intracellular contents come outside, it will automatically trigger inflammation. But in apoptosis, I have only caspases and endonucleases. There is no phospholipase. When there's no phospholipase, cell membrane is not damaged. And when the cell is not damaged, why should I need inflammation? I won't have inflammation at all, right? So apoptosis will not have inflammation because if they ask a question why apoptosis doesn't have inflammation, the reason is there's no active cell membrane damage or no phospholipase activation in case of apoptosis, right? Next question. Let's see. Again, a simple one. Whatever comes to your mind, A, B, C, or D. What's the right answer? A, B, C, or D? Anything. See, if it doesn't matter, just type I don't know. That's also okay with me. Okay, Nayak has gone with B, Lion has gone with B, Priya has gone with B. Question is, which of the following is an example of extrinsic receptor ligand pathway in apoptosis? If you remember apoptosis, you have two major pathways, right? The intrinsic pathway, extrinsic pathway, and common pathway. Almost similar to your coagulation system. I have an extrinsic pathway, I have an intrinsic pathway, and I have a common or an execution pathway, right? The extrinsic pathway for me is your receptor or the ligand mediated. If you remember, what we said was all living cell will have an FAS receptor. Great. Okay, and the cell will have an FAS ligand. The WBC generally, the lymphocyte will have an FAS ligand. It comes and binds to a dying cell, binds to it, and that triggers a pathway called an FADD. Just a leading question to all of you guys. Tell me, FADD or the extrinsic pathway of apoptosis activation activates which caspase? Can you guys recollect the number? There's two particular caspases will be activated as a result of this pathway. FAS receptor, FAS ligand activation, FADD. Perfect. It is great. It is caspase 8 or caspase 10. Perfect, right? Of this, can anyone tell me what's human caspase? Rahul's specs is not gone. I misplaced the specs somewhere. It will come. I don't think so. It will go till I live. Okay. Caspase 10 is a human caspase, right? So the question is on human caspase. Caspase 10 is a human caspase. It doesn't matter. For me, caspase 8 is something which is discovered in a lower animal. Caspase 10 is a human counterpart of it. That's all. Most of the caspases we discover only in lower animal because it's very difficult for us to do a research on a living cell of a human being. Fine. Perfect. Caspase 10 is a human caspase. Great. Next question. Again, comment on whatever comes to your mind. Right, wrong, we'll see later. It's completely fine if it's wrong. Okay. Right answer. Swati has gone with B, Lion has gone with B. Simple question, right? The question is on early alterations which is seen in a reversibly injured cell. Fine. Here, if the option would have been detachment, that would have made sense, right? But these are word plays. Most of the NEET PG exams, next exam question will be like this. Please read the options very carefully. Nuclear condensation and ribosomal detachment. Yes, there's a possible in a reversible cell injury, not an attachment of ribosomes. Organ swelling, yes. Plasma membrane blipping, yes. Ribosomal detachment, yes, right? Option B, like you guys said, is the right answer, right? Definitely that's the right answer. Mitochondrial damage and ATP. ATP will never be overproduced when it's mitochondrial damage, right? So this option per se itself is wrong. Mitochondrial damage, can it happen in reversible cell injury? Yes or no? The damage to mitochondria, is it possible to happen in reversible cell injury? It's definitely possible to happen in reversible cell injury, right? If you remember, we read about something called an amorphous densities in mitochondria, right? I can have mitochondrial damage in reversible cell injury. That's what results in amorphous densities in mitochondria, any electron microscopic image, right? It can happen. It will not be irreversibly damaged. Damage can definitely happen. ATP will not be overproduced. When mitochondria is gone, ATP is going to be underproduced, or it will be lost, fine? So like I said, option B is the right answer. Perfect. Next question. Again, read the question. I'll keep myself quiet for some seconds. This might be something which I have not taught you in the first chapter. I'll teach you this sometimes later, but let's listen to this question. Okay, Nayak has told the right answer. Anyone else? Then C. Okay, this question is on a reperfusion injury. It is there in the first chapter. I left purposefully that it will be difficult for you to understand reperfusion injury until you go and know and understand what does reperfusion mean. Okay, let's go background about this question. Then let's go to the option. What do you think will be the best treatment for a myocardial infarction? My heart, one of the blood vessels of the heart is blocked. What is the best treatment? What comes to your mind? I need not answer. I need not tell you to answer from whatever you know. Just a normal question. Heart is blocked, vessel is blocked. What will be the best treatment? The best treatment is to remove the block, right? That's the best treatment. Obviously, remove the block, right? Perfect. So when I have a myocardial infarction, the best treatment for MI is to remove the block, or in simple terms, TPA, or I can just use terms thrombolysis. There's a thrombus, I use thrombolysis. I can use an angioplasty, percutaneous coronary angioplasty. I can use that, or I can use this, right? Great. Right? I'm going to use thrombolysis. Now, because of thrombolysis, what happens is to a dying myocardium, there will be reperfusion. Okay? What cause reperfusion? Now, let's see what exactly will this reperfusion do. Right? I'm having this myocardium, which is kind of dying. To this myocardium, I have had a blocked vessel, which I am introducing it again. I'm introducing new blood again. Okay. So can I say this new blood will have new reactive oxygen species? Is that right? Yes, it's definitely possible, right? I can have a new reactive oxygen species. Can I have new calcium coming into the tissue? I can have new calcium. Can I have new WBC coming from a new blood? I can have new WBC also. So now this tissue is dying. If reactive oxygen species comes inside, will this tissue have enough antioxidants like your catalase, superoxide dismutase, and your glutathione peroxidase? Will they have them? They won't have them, right? So because it's a dying tissue, the amount of free radicals coming inside is more, and the dying tissue cannot tolerate them. So what happens is, unfortunately, I'll have more damage. That's called as a reperfusion injury. My goal was to make sure give blood supply to the dying tissue and revive them. But here, unfortunately, the opposite happens, right? Now, with this information, let's go to the question. A patient undergoes reperfusion therapy for a myocardial infarction. Despite improved blood flow, the cardiac enzyme troponin continues to rise. So I have treated, which means ideally it should come back to normal. Now what's happening is, despite the problem, it's continuing to rise. So what is the mechanism for the continued elevation? In other words, the question is asking, what is the cause for your reperfusion injury? Okay? The cause for reperfusion injury is simple. It is production of oxygen-derived free radicals. That's the right answer. Option C is the right answer. Fine. Now, then how do you treat MI? If this is true, ideally there's no way to treat MI, right? Everything is gone. So the way to treat MI is same reperfusion only, but within something called a golden hour or critical time. Reperfusion injury happens only when I give it after some time. So with research, we said for stroke, within 4.5 hours of stroke, I have to give perfusion again. Then it's good. Like that for every organ, I have an ischemia time. Before that time I give, the reperfusion is good. After the time if I give, the reperfusion is bad, right? That's the whole concept of reperfusion injury. If it's good, if it's beyond a certain limit, it's definitely bad, right? That's the concept of reperfusion injury, okay? We'll read them again when you come to myocardial infarction and cardiac pathology. It's just a starting point here, okay? Next answer. Again, whatever comes to your mind, tell the answer. Okay, great. Line is started B. Shreya, like I said, no, for any treatment, I have a side effect, right? So I go and take the risk benefit analysis. So when I take the risk benefit analysis, what happens for me is when I give before the set time, my benefit is more and the risk is less. If I give it after some time, the benefit is less and the risk is more. That's why we have given the timeline. I hope it's understandable, right? Okay. Harsh and Nayak, next time when you do an MCQ, please read the questions carefully. This is a silly mistake. You can easily avoid. The question is based on reduced capacity of cells to divide. Is it telomere elongation or telomere shortening? Harsh and Nayak. It is telomere shortening. I am 100% sure you know that. But what has happened is you saw telomere, suddenly you wrote the answer, right? Just a second. Just a second more. Make sure next time you read the entire question completely because there are possibilities you'll have all except. The question might be something. At last, I'll have all except or double negative, not common, like those things, right? Those are careful things you might lose the answer. So please be careful. Option A is wrong because not telomere elongation, it's telomere shortening. This entire process name is replicative senescence. Senescence is old age and dying. That's what senescence. And here, the senescence happens due to replication, right? More and more and more replication, the telomere will become shorter. That results in senescence. That's what we call as a replicative senescence, right? I hope you understood the error. Don't make that silly error. These are tiny mistakes. I'm sure you'll overcome it. Fine. Bound to happen, but don't make the mistakes in main exam. Fine. Next question. Answer. It's a very simple one. We learned a long thing about this. Option A. Option A. It's the definition of that calcification, right? In the pathological calcification, it occurs due to locally in dying tissue despite normal serum calcium levels. As the term says, this is abnormal. We know that, and calcification is calcification, obviously. Right? So the answer is dystrophic calcification. Just to complete, what will be the serum calcium levels in case of metastatic calcification? Normal, reduced, or elevated? Perfect. It has to be elevated, right? So it has to be elevated in case of a metastatic calcification. It will be normal in case of a dystrophic calcification. Perfect. Fine. That's the difference here, right? And can anyone give me one example of dystrophic generally change? Dystrophic. Samoma body is an example of dystrophic calcification. Cardiac, valvular calcification, calcification in the vessel wall, all of them are examples of dystrophic calcification, right? Perfect. Great. Okay. Next. Yes, atherosclerosis as well. Again, it's a very simple one. Very simple one, right? Perfect. It's anthracosis. Anthracosis is completely normal for it's. If you look at Robbins, it will be written a person who is living in urban areas and person who's a smoker can have anthracosis. But I would say almost every place in the country is or the world is polluted, right? If you're in a carbon negative environment, yes, you might not have anthracosis, but you have breathe air in a polluted area, it will go and get deposited in the lung as well as in the hilar node. Remember this, anytime a person's hilar node will be black only. Most of us, if you're an adult living in India for quite some time, not just India, any part of the world that's polluted, you will have black color calcific, black color hilar lymph node. If there's any question asking, is it malignant melanoma? Don't jump and write, right? Because it's instinctive and it's like, wow, it's a disease. Black color, it hits you and you'll tend to write as malignant melanoma. Melanoma in hilar lymph node is very rare because in lung is where hilar lymph node drains, right? Lung melanoma is very rare. Esophagus melanoma is very rare because they don't have melanin. Melanoma is common in skin. It will not go to the hilar lymph node, right? So if hilar lymph node is black, most often, please don't misdiagnose. It cannot be melanoma. Very unlikely to be melanoma. Most likely is your anthracosis will be, right? Okay. Next question. What's the answer? It's a very simple one. How many of you are giving the DPPs regularly? These are questions from DPPs. Just to make sure you give them, I want you guys to give DPPs. If you're an essential batch student, please don't miss them. Now both means one and the same. Melanoma or malignant melanoma, both means one and the same. Fine. Perfect. Good. So it's a simple question. What happens in tattooing is the macrophages or the Langerhans cells of the skin is going to eat the pigment and it's going to store them, right? The dermal macrophages are the one which is going to consume them, which stores them. It's normal finding here. Any one of you is having tattoo here? Tattoos are fine unless and until it causes a huge problem. Sometimes it might have a reaction. Most of the time, just the pigment will be there in the macrophages. That's all. It will not elicit a reaction. Fine. Next question. Great. Great. Amazing. Right. I want you guys to remember this term forever. It's hyaline. Right. We'll use this term in simple words. I know it's pink in color, homogeneous, glassy pink in appearance, extracellular space. I don't know what it is made of. I just know it's a pink color. Whenever something is pink in color, I use the term hyaline. We will read in systemic pathology in multiple places. There's something called as Mallory hyaline bodies. It is pink in color, that's all. And Mallory discovered that. Hyaline arteriosclerosis, seen in case of a hypertension, because I have pink color in the arterio, that's all. Hyaline membrane disease in the lung, because the pink color membrane in the lung, that's all, right? So whatever we did in general pathology is the base for anything in medicine. We can name it, we can understand it, we don't memorize it, right? So that's all about today's question. I think we saw 10 questions today. Rahul, like I said, no, I know in amyloidosis what is getting deposited. So I call the term amyloid, that's all. Hello, Roy. Right? That's the reason. If something is not able to quantify what it's getting deposited, I generally use the term hyaline. Right? Okay. So let's call it a day today. We'll continue with the RRSs maybe I think next Monday. I'll go with inflammation chapter MCQs next Monday and the next day. 2 more days for MCQs regarding inflammation. Then we'll go to the 4th chapter and from there go. Fine. Okay. Thank you. Bye bye.